Okay. Good morning, all. Welcome to the morning session of the Clinical Epidemiology Unit. Today, we are going to take a modification of the AGREE tool. AGREE tool is meant for guideline users, either to develop a guideline or to evaluate somebody else's guideline or to decide whether to modify somebody's guideline. The criticism of the AGREE tool was that it didn't look enough at the viewpoint of the policymakers or the healthcare personnel or the patients, and the usability of the guidelines wasn't adequately looked at using AGREE alone. So there's a modification called AGREE Rex. I won't spoil the surprise which Reba has got for you. Dr. Reba is our assistant professor in medicine, and she's going to take you through the AGREE Rex tool, and she's going to use a guideline on COVID as an example to explain the Rex tool. So over to Reba.
Good afternoon, everyone. Today our topic is the AGREE Rex tool for Guideline Appraisal. The Rex stands for Recommendation Excellence. So the outline is going to be as follows. We look at a clinical scenario. We'll briefly talk about what is the clinical practice guideline, why should we use the AGREE Rex tool, and what is this particular tool, and how to apply this tool on a clinical practice guideline. And at the end of it, I'll just give a brief gist of the guidelines, as well as we'll resolve the case scenario. So moving forward, you're doing your post-MD general medicine service obligation in a secondary care hospital in Jharkhand. There is only 1 more month to go. All of a sudden, you hear the chilling news. COVID has resurged. So initially, you warn in self-pity, and then you pick up your moral. And then you find yourself in administrative meetings as the hospital rallies around to cater to this new emergency. You and your team need to get ready to accommodate the surge in patients. You also need to develop a hospital protocol to manage patients tested positive for COVID. You search to see there are guidelines and any online resources available to help you. So what are clinical practice guidelines? So they're basically systematically developed statements informed by a systematic review of evidence, as well as an assessment of the benefits and harms of care options. It is designed to optimize patient care. So if you look at how WHO develops their guidelines, the first step is actually to have a scope of the guidelines. Then you need to formulate questions. And then you need to look at all the evidence and synthesize information. Then you must grade the evidence. And then you finally formulate the recommendations. And it's very important that the benefit of a clinical practice is only as good as the quality. So if the evidence is not good, your clinical practice guidelines is also not good. So what is this grade evidence to decision framework? So it's basically a framework for people making and using healthcare policies for them to actually come to recommendations as well as decisions. So the first step is policymakers and constituents, they look at a problem, and if it's important enough, they need to make a question with the technical team. So with the help of the technical team, they formulate a question, and then they look for all the evidence to actually answer the question. And the technical team synthesizes all the evidence, and they populate this framework called the evidence to decision framework. So it has a lot of criteria. First is benefits and harms of the options, your recommendation options. It looks at the values and balance of these effects. It looks at all the resources that you need to implement the recommendation. What is the cost effectiveness? And is it equitable? Is it acceptable to the patient? And is it feasible? So they populate this table, and then a panel actually goes through the framework, and then they decide to adopt it into a guideline. And once it's adopted, it gets disseminated to other healthcare policymakers, patients, as well as healthcare providers for them to follow in their practice. There are other evidence to decision framework. This one is by grade. There's also the WHO Integrate framework. So what is it AGREE? So not all clinical practice guidelines are, the quality is variable. So you need to have a consensus if the quality of the guidelines is good or not. So there is something called AGREE, which is the Appraisal of Guidelines for Research and Evaluation. They have developed a tool called the AGREE tool, which has now become an accepted international criteria for guideline evaluation. So it has 6 main domains. It looks at the scope and purpose. It looks at the stakeholder involvement, the the rigor of development, that is the methodology of the systematic review. It looks at the clarity of presentation. It looks at the applicability as well as the editorial independence. 6 domains and it has 23 items, which is listed out here as follows. And ideally, to apply the Agri2 tool, you need actually 4 assessors. And each one of them go through all the items, 23 items in the 3 domains. And then they give their own values. And at the end of it, for example, a domain, each of the 4 appraisers will give you a total. And then you have to calculate the total. And then you come to the overall domain. That is your obtained score, which is 53, minus the minimum possible score, which is 1 for each of the items. So you have 3 items. So 3 into 1 into 4 appraisers, which is 7. Or you can have the maximum possible score, which is 7 is the maximum score for each item. So you can have 7 into 3, 21, into 4 appraisers. That will come to around 84. So based on this, we come to a final domain calculation. For this particular example, it's 57%. Generally, more than 70% means a good quality guideline. 30 to 70% is a moderate quality. Less than 30% is a poor quality. If you want to go in detail on how to apply the Agri2 guidelines, you can look at this YouTube video, which was uploaded 1 month back. Now, why is there a need for a new tool? So some researchers, they found out that even though that some guidelines for the Agri2 tool was really good, they were not really able to apply it practically. The reason is the Agri2, it focused more on the methodological quality as well as the internal validity, and they didn't really look at, focus much on the external validity of the recommendations. So in 2020, under this team, they developed Agri-Rex. The Rex stands for Recommendation Excellence. So it's a valid tool to assess the quality of the guideline recommendation and a strategy to inform the development and reporting. So the 3 most important things they're concentrating on is credibility, trustworthiness, and implementability. So credibility means that the recommendations are based on the available evidence and is appropriate for the target user as well as the patient population. And they must also consider the value of all the relevant stakeholders. So who are these stakeholders? They can be the guideline developers, they can be the policy makers, they can be the healthcare professionals, and they can be the patients. So they must consider all the values, and finally they must see if it's actually implementable or not. So when they initially validated this tool, they had 4 domains and 11 items. Subsequent to validation, based on the feedback of the participants who validated the tool, they have come down to 3 domains as well as 9 items. The 3 domains are as follows. One is clinical applicability, which includes item evidence, applicability to target users, applicability to patient and population. The domain 2 basically looks at values and preferences of the target users, the patients, the policy makers, as well as the guideline developers. And finally, the implementability is the purpose as well as the local application and adoption. So today we'll be looking at this particular guidelines, which was updated by NICE. It's called the COVID-19 Rapid Guideline Managing COVID-19. So initially it was published in 23rd March 2021. This is a living systematic review. That means every week they sit and they look at all the evidence and they keep updating it. So the last update was in 1st May 2025. So the bottom you have the guidance. If you click on this, you actually go to the actual recommendations, the guidelines. They also have tools and resources. They have evidence for your recommendations, and they also have a history where they have shown how they developed particular guidelines. So what is the scope of this guidelines? So this guideline is basically to cover management of COVID-19 in babies, children, young adults in community and hospital settings. It includes recommendations on communication, assessment, therapeutics for COVID-19, NIV support, preventing and managing acute complications, and identifying and managing co-infections. So it has a clear objective, and also clearly mentioned the population to whom the guidelines will apply, and the health questions are also clearly mentioned. So if you look at the guideline proper, these are the contents. It has a communication and a shared decision making, a lot of emphasis on communication. It has assessment in the community as well as in the hospital, preliminary management in the community as well as the hospital, and they also look at therapeutics for COVID-19. A couple of drugs which we can use for COVID-19. And they've also looked at managing few acute complications like an acute kidney injury, an acute myocardial injury, as well as venous thromboembolism prophylaxis. And a few co-infections, that is how to manage a fungal pneumonia and COVID-19 associated pulmonary aspergillosis. They've also talked about follow-up and rehabilitation as well as palliative care. Just to show you how the guidelines are, this is the format of the guidelines. So they will have a recommendation number written here. We will have the recommendations. And they also have a short explanation of why we need this recommendation. They have a rational section which is in the same recommendations. The total body is around 80 pages. The top 40 pages are all recommendations like this. The bottom 40 shows all the rational section. And then you have other links which actually go to your evidence. So this is the supporting evidence which is available for this particular article. Under the tools and resources, you have other things like based on assessment tools which you can use in your local healthcare system, and some implementation support, and some summary versions which we can go through to the end. And this is the history part of it. Basically talks about how they have developed these guidelines. This is the for each question they have the peer review they have told us, shown it. Overall, the total number of PDFs supplementary material is around 56. So if you want to actually apply the Agri regs, you must go through all the 56 PDFs for you to make a proper judgment. And at the end of the guidance, they have told how to find more information. That is the same link I have showed. Yeah. So let's go on. So first question. Item 1 is the evidence. So in order for recommendations to be of high quality, they should be based on a thorough review of the quality. So some things which the guideline, the evidence base should have is a risk of bias for a particular recommendation. What is the consistency of the result? What is the directness of the evidence? What is the precision? What is the magnitude of the benefit and harm? Is there any likelihood of a publication bias? Is there possibility of confounding factors? Any dose response variant in case of drugs? So if you look at it, so they have the evidence for all their, most of the recommendations they have an evidence, that is the therapeutics. So overall, I would say that the transparent referencing towards detail was present. So every recommendation had one reference to the evidence. But the only thing is the quality of the evidence, that is confidence interval, magnitude of benefits and harms, is only present in the appendix, that is in the external document. It's not mentioned directly into the main guidelines itself. I felt for readability it would have been better if they could have summarized the quality appraisal for each recommendation within the main document itself. Some old recommendations, some important recommendations have been adopted from the technology appraisal book. So the individual evidence is not actually displayed. So we'll go to one example. So they have a recommendation that is consider awake prone positioning for people in hospital with COVID-19 who are not intubated and have higher oxygen needs. Okay, so then they have gone around to tell how to prone position the patient, what are the contraindications for prone positioning, and this is the information for conscious prone positioning for people with COVID-19. And they have also given us a short explanation of why the panel made these recommendations. They have also given a link of where this evidence is found. So this is actually the rationale for prone positioning. So the brief just is given here. Evidence shows that awake prone positioning reduces the need for intubation compared with standard care. Although evidence is limited and not low to very low certainty, the panel agreed that awake prone positioning may be beneficial for this population. So detailed quality domains like bias, consistency, dose response are not summarized in the main document. So if you click on the link to the evidence, you come to another PDF, which is almost 87 pages long, which is very detailed. They have given you the review question, the methodology, their evidence to decision table. They have also appendices for the FIFO statement, the literature search strategy, the PRISMA diagram, the included studies, the evidence tables, the forest plots, and grade profiles. In great detail, they have given the evidence. So the first question is, any risk of bias has been assessed. So if you look at the screenshot from their evidence table, it says all studies were rated at high risk of bias, and they have downgraded the grade outcome for the risk of bias. Why did they think of risk of bias? Because a lot of studies had lack of blinding and there were some issues with protocol adherence. So they have clearly considered risk of bias. Just one example, there's one study by Fralick et al. We have applied the Cochrane ROG2 risk of bias tool. So here, if you see, there was some problem in the deviation of the protocol because some patients they could not spend time prone and those poor adherence to the intervention group. And they also felt that there was a risk of bias during judgment because they were not blinded, so they could have been biased in assessing the outcome. So they have given the study high risk of bias. Another study by Taylor, they have again given high risk of bias because they felt there was some problem with the randomization. And they also had a problem with the intervention. That is, in the control arm, 23% of the patients had actually attended prone positioning, Whereas in the intervention arm, that is prone positioning, only 37% of the patients had actually undergone prone positioning. So there was significant high risk of bias. Second thing is they have looked at the indirectness of the study question. They have looked at publication bias. And they have looked at the precision also. So the relative rate has been given and they have clearly written the confidence interval for the outcomes. If you see for this one prone positioning, actually there is no mortality benefit. However, the need for intubation is slightly less in patients who are actually getting prone position. We have also given forest plot with individual studies and the overall effect size for all the various outcomes. They have given a table for all the adverse events also. And they have also looked at the benefits and harm. So they have done a risk, like a balance between the benefit and harm. So they have shown that awake prone positioning reduce intubation rates and increase the median time to intubation. The evidence did not show increase overall harm. And they have also looked at dose response gradient in the sense like the more you prone position, perhaps it will be more beneficial. So overall, I would say that for whatever they have given evidence, it's a very high quality evidence, clearly accessible. But some drugs, for example, molnupiravir, nirmatrelvir plus ritonavir, sotrovimab, tocilizumab, remdesivir and tixagevimab plus silgavimab. These are some few drugs which they do not have this evidence, detailed evidence for. So actually, they got the evidence from the NICE Technological Appraisal Committee. So what is this committee? So basically, this NHS, they have a system. When there are new drugs, they need to balance between the evidence for the drugs as well as the cost effectiveness of the drug. So they have an independent committee called the Technology Appraisal Guidance, which actually goes through it. They do their own appraisal and then they recommend. So this is very important for NHS because once NICE makes any guidelines and they tell a drug can be given for a particular condition, if the patient has a condition and the treating doctor feels that this drug would be of benefit, the drug must be available in the system within 3 months of the guidance being formulated. So they must make sure that these drugs are available. That's why it's very important for them to have technology appraisal guidelines. So for those previous 3 drugs I showed you, they got the evidence from this particular body. They themselves have not done a particular appraisal. So overall, I would say that I gave it a point of 5 for the evidence. And suitability for our use also, I would give it 5 because it won't change. The next question is applicability to target users. So does it apply to the guidelines target users? And yeah, so does it basically go along with our target patients and population? What is the direction of recommendation? Have they clearly mentioned its favor of a particular recommendation or it's against a particular recommendation? And they have also told, does it show the strength of the recommendations? So if you look at overall NICE, it's basically the National Institute for Health and Care Excellence. It's an independent public body that provides national guidance and advice to improve health and social care in India. So they themselves are told that all the guidelines are actually for health and care practitioners. So any recommendations for NICE is clearly meant for the clinicians working in the NHS system, in the primary, secondary as well as the tertiary setting. So for the target users, it could be any clinician or a GP intensivist who's going to help take care of COVID-19 patients. And it's also relevant because they have talked about up-to-date recommendations on oxygen therapy, anticoagulation, corticosteroids, drug therapeutics, escalation, COVID-19. So very relevant for the clinicians. And also direction of recommendations clearly mentioned. That is if it's if it is in favor or against a particular intervention. And as I showed you previously, they have looked at the harms and benefits. So if you look at the contents also, a few recommendations are structured by context, like whether in the community what you can do, in the hospital what you can do, how to manage them in the community, how to manage them in the hospital. So if I want to apply this in my local practice, which is the secondary care hospital, there were some more topics which I would have liked more information on, which was not there in this current NICE protocols. So I just made a list of them. One is I thought the disease was not classified. So in that in their guidelines, they have told to assess for severity, use the MRC dyspnea scale. You can use the Muse2 score for adults. For pediatrics, they talked about pediatric early warning scores. They've also told severe COVID is these symptoms, that is shortness of breath, reduced oxygen saturation. But they've not really told you what is mild COVID, what is moderate COVID, what is severe COVID. But if you look at the WHO guidelines for COVID-19, they have clearly told what is critical COVID, what is severe COVID, what is non-severe COVID. If you look at the IDSA guidelines for COVID management also, they have classified them as mild to moderate based on a particular oxygen saturation, severe but not critical COVID. Critical COVID if the patient needs non-invasive ventilation or hypooxygen. Critical COVID-19 requiring mechanical ventilation. And the WHO guidelines also has a link to the BMJ Magic app where they have put an infographics on how to classify disease severity, which is not there in the NICE guidelines. The next important thing is, it would have been nice if they had recommendations based on the disease severity. What they have done is they have given a list of all the therapeutics, but they're not told exactly for mild disease you can use these, for moderate you can use these. On the other hand, if you look at the IDSA guidelines, clearly they have told, based on the care locations, like for an ambulatory patient, mild to moderate, you give these drugs. For a hospitalized patient, you give these drugs. For a patient who's hospitalized critically ill, so not critically ill, you can give corticosteroids, remdesivir. Patient who's critically ill, so everything is it's very nicely classified based on their setting as well as severity of COVID. The third thing is they not only talked about infection prevention and control methods. So what measures can be adopted for source control? How long should the patient be isolated? How and where to isolate? And what are the dimensions of the room, bed spacing? What about waste disposal? How to form healthcare teams to specifically look after COVID-19 patients? And also using disposable or dedicated equipment. So all this is not mentioned in the NICE guidelines. The next thing is what about protection of healthcare workers? So when I typed in mask into the guidelines, there were only 3 references to mask and all of them are about CPAP or a NIV mask. But on the other hand, if you look at the WHO guidelines, they have told, okay, you have to use appropriate use of PPE, you have to do universal masking, environmental cleaning, prevention of needle stick or sharp injury, safe case management, practice hand hygiene frequently, then ensure healthcare workers avoid contaminated environmental surface. So they have actually looked at the well-being of the hospital care staff also. The next thing is, what about COVID care pathways? So I think patient flow pathways could have been included. If you saw the WHO pathway, whatever has a green background is actually screenshot from other guidelines. Okay. So they have clearly mentioned, okay, when a patient comes to the community, you need to screen for COVID and you have to triage those patients, clinically assess them, and then send them either to the ward, that is when they are more mild or low risk moderate. ICU if they're typically ill. After you treat them and how to release them from the pathway. That could have been mentioned in this. And the last thing which I thought would have been useful is how to actually using ethical principles like using duty of care, non-abandonment of patients, protecting the community. How to be ethical as well as make proper decisions regarding allocation of scarce resources. This also could have been talked about in the guidelines. And finally, administration-related questions like how to prepare and be ready to surge critical care capacity. What are the important list of important drugs and healthcare equipment also they could have added to the guidelines? It would have been useful for a policy maker. So overall, I would say for the NHS system, it's an excellent guideline. So I gave 5. But if I really want to apply it in my own center, I downgrade it and give it 4. The third question is applicability to patients and populations. So whether they have considered relevant outcomes for the patient and does it improve the desirable patient outcomes? Does it mitigate undesirable outcomes? And how did they find out that which outcomes are important for the patient? And did they actually tailor the recommendations to apply for the individual? Okay, so what do you think are important outcomes for patients who have COVID? So there's already a study done by DMJ at the start of the pandemic, but they have actually done a study and they have looked at outcomes which patients would probably feel which is important. So some of the outcomes are functional status, like health-related quality of life, general physical functioning, vitality, energy, the mental functioning, social functioning. Important clinical outcomes, like patients are worried about the survival, they are worried about whether they need to go into the ICU, disease post-severity, will they have any organ damage, how long will their hospitalization be, and they're also worried about symptoms. So they feel better once they're asymptomatic. So these are important outcomes. Now these specific outcomes, there's nowhere in the guidelines that says how they formulate the outcomes. But because they have developed these guidelines, it's very obvious that the entire guidelines is designed for the benefit of the patient. So the recommendations are to improve the outcomes. Only thing is there's no mention of how outcomes important to patients were integrated during the recommendation development. It's not explicitly mentioned. But when NICE usually develops guidelines, lay people are part of the committee. So this COVID-19 guidelines did not follow the usual guideline development process. So whenever there is a health and a social care emergency, NICE has a separate way to develop that guidelines. But in that also, they have to have lay members in their independent advisory expert panels. So obviously, this guideline development process had lay members. They probably did help formulate patient-related outcomes, but it's not explicitly mentioned in the guidelines. But on the other hand, if you look at the WHO guidelines, they have something called multi-system inflammatory syndrome in children, how to treat that. So here they have really talked about the patient outcomes. For the previous recommendation, the guideline development group members prioritize outcomes with severe and critical COVID, taking the patient perspective. For these new recommendations, the guideline development group concluded that the values and preferences of children and adolescents with MISC may differ from those used in previous recommendations. So they have done a new targeted outcome prioritization exercise. And the new prioritized outcomes were used to update the meta-analysis. So they have actually gone and done a small study, found out what are the new outcomes, and they have integrated into the guidelines. So this was not there in our NICE guidelines. And the next thing is, based on the age and comorbidities, that is pregnancy, pediatrics, immunocompromised, they have tailored the therapy. So for every recommendation they have told, for pediatrics, this is the recommendation. For pregnancy, you can follow this link. For example, COVID-19 pregnancy, you go to the Royal College of Obstetricians and Gynecologists information link. And for children, you go to the pediatrics link. So overall, I must say, applicability to patients, I gave it 4 and 4 in both the domains. So the next question is, we go to the second big function, that is whether values and preferences of various stakeholders considered. So the first stakeholder is target users. So where clinicians actually consulted in terms of the recommended actions, do we need to actually learn new skills or do we need to adapt our current routine? And is there any flexibility and individual patient tailoring option in these guidelines? And have they described the range of recommended actions that are acceptable to the clinical community? So if you look at it in terms of topic selection, that actually comes from the relevant commissioning body like the NHS England. But if you look at who's involved, the target stakeholders who obviously involved healthcare workers, they're part of the draft guidelines. And even before they draft update, before they can publish it, the target stakeholders are consulted. So definitely healthcare professionals, the values and preferences are consulted. Okay, so the next thing, this is just to show that clinical flexibility and provision for individual patient tailoring is present. For example, under the baricitinib evidence panel, I just highlighted it. It says, as such, the panel agreed the clinicians should consider the clinical and contextual factors when deciding whether to use baricitinib or an interleukin-6 inhibitor or both. These include availability, people's preference, severity of illness, and deterioration. So overall, there is clinical flexibility, and we can individualize our patient management. And if you also look, there are a lot of links to external documents. So people like of all different experience levels can actually use it. Maybe people who do not know how to manage delirium, when they look at these guidelines, they can just click on how to evaluate and manage delirium. So if you press that, you come to an entire new NICE guidelines on how to prevent diagnosis and management, hospital and long-term care. So it's actually helpful for a lot of different experience level healthcare workers. They also have given a protocol on how to escalate treatment. And they've also given a link for that, decision making for escalation of treatment and referring for clinical care support. They've also mentioned the skills and competencies that you need for certain intervention. Like for example, for patients when you're giving non-invasive support, it's a staff caring for people with COVID-19 having CPAP should have appropriate skills and competencies. And they've also given a link to what skills that they need, which is actually the Faculty of Intensive Care Medicine and Intensive Care Society guidelines on the provision of intensive care services. They have also given you some extra links to teach you actually how to go about giving NIV support for the COVID-19 patients. It talks about the infrastructure you need. It talks about the equipment that you need, the staffing that you need. And also has given you a clinician decision support, like based on the oxygen saturation, how to proceed. You put them in the ward, you send them to the ICU, or what care you give. So all that is actually useful for practical application. But all of them are not in the main body. I think is a added link to the original guideline. And they have also mentioned the rationale for each recommendation. So overall, I would say that for the values and preferences of the target user, that is the healthcare workers, I give it 5 and 5. Next thing is whether values and preferences of the patients considered. So for that, we must know whether the patient has been sought and is it acceptable for the patients. And for some people, the choice may differ. Some recommendations, like maybe 100 patients will agree for one recommendation. For a different recommendation, maybe 50% patients might agree, 50% may not agree. So some recommendations they should actually tell, okay, this one there can be a lot of patient variability. That is actually not mentioned in the guidelines. I will come to it. Okay, so when it starts off itself, it tells your responsibility is you have to apply with the preferences and values of the patients or the people using the service. You must make decisions appropriate with the circumstances of the individual in consultation with them and their families and carers or guardians. And even if you look, it says you must explain the people with COVID, their families, carers, and close contact. You must give information so that they should take part in decision about their care. You must support their mental well-being. So there's a lot of emphasis which is placed on shared decision making and equity. But this, just because they have mentioned all this, doesn't mean that this was applied during guideline recommendation. They're telling you when you apply, use the guidelines, consider patient values. So have they really looked at patient values in the guideline recommendations? So this will be for my views. So there's a lot of emphasis on shared decision making. And they have considered the patient values and preference in the development process. They have considered acceptability and feasibility. So, for example, steroids for COVID-19. Whether to give steroids or not, what do you think patients' values are? So, it's written over here. The panel were not aware of any systematically collected data on patient preferences and values. The panel inferred that, in view of the probable mortality benefits for people with COVID-19 who need oxygen, most patients would choose corticosteroids after shared decision making with the healthcare professionals. The panel also inferred that because of the risk of harm, most fully informed people with COVID-19 who do not need supplemental oxygen would not want to have systemic corticosteroids. So they have taken the patient views. They have also looked at the acceptability. So the panel considered that acceptability of corticosteroids would be very high, given the widespread availability, ease of oral ingestion in any setting, as well as established safety profile. And they have also looked at feasibility. Because it's very widely distributed, it must not be a very big difficulty in getting steroids. But what they have not considered is, what about the patient variability? This I have taken from WHO guidelines. So for example, they have given a guideline that patients who have COVID-19, who are not hospitalized, when you send them home, should you give them a pulse oximeter or not? What do you think? Would you want to have a pulse oximeter or not? Why would you want to have a pulse oximeter? Sorry?
In case of subjective resistance, checking.
Yeah, so if you have a normal value, it's good. Second thing is, if you can earlier detect and pick out your disease, can it be any harm in giving a patient a pulse oximeter? There could be some harm. Why some patients can become extremely anxious and stressed. They can misinterpret the data and they can possibly have a false assurance. But overall, they have written that most of the patients would want a pulse oximeter. So they have written there's no substantial variability expected. Now, on the other hand, look at thromboprophylaxis. So, in patients who have COVID-19, who don't have any thromboembolism, should you give them therapeutic dose of anticoagulation? Should you give them prophylactic dose of anticoagulation? Okay. Most of us would want a prophylactic dose. But here they have mentioned, most well-informed patients would not want to receive therapeutic or intermediate dose of anticoagulation because there's a high chance of bleeding. But some well-informed patients might want to receive the intermediate dose of anticoagulation. So in that case, there can be some variability. Okay. So that was not really mentioned in this guidelines. But overall, they have looked at the patient values or feasibility acceptability, so I have given 5. Now the next thing is, what about policy and decision makers? So have the needs of them been considered, and the recommendation does it reflect on the system level decision making? And have they looked at health equity? And they've also looked at whether any changes to policy should be made. So if you look at the policy makers for the NICE, that is the stakeholders, we have a whole list of stakeholder body. And all of them have been considered when they develop the guidelines. So they have looked at the impact of recommendations on the resources as well as health equity. So clearly they have talked about this one entire, each evidence has one equity page. They also have looking at the resources page. The second thing is, if you look at all the drugs, all the drugs basically reflect the NHS resource level. So, for example, Nirmatrelvir plus Ritonavir is recommended in this group because the likely cost-effective estimates are within what NICE considers an acceptable use of NHS resources. So, every drug recommendation is only what the NHS considers as useful. So, it's all within the system of NHS. For example, all the drugs, I just put the Indian value on the side of it. For example, Sotrovimab costs around some 2,54,000 rupees. Tocilizumab costs this much rupees. But NICE, NHS, they have company commercial arrangement. So for each of the drug, they get everything in a subsidized rate, even Remdesivir. And for them to arrange this commercial arrangement, you could just have to contact these email IDs. So overall, I would say the recommendations are it's only for the NHS system. And in NHS, irrespective of the patient's income or background, all policies should be applicable to all patients. So this is not applicable to other countries outside the UK. So overall, and if I put this up in our Google to look at India Mart, is it available or not, you can see that it's written currently out of stock. Okay, so overall, I would say that for policy makers in the NHS system, it's 5. But for policy makers in Indian setting, it's just 2. Then the third last item is values and preferences of guideline developers. Developers. That are the people who actually made the system. So it's written over here, the recommendations in this guideline represent the view of NICE, right after careful consideration of the evidence available. That means definitely the guideline values and preferences have been considered. So in the evidence section, there's a clear documentation of method of balancing harms and benefits before recommending particular intervention. And they have also considered the patient preference values, resources, equity, feasibility, and acceptability. And they have clearly mentioned the conflict of interest as well as committee member roles in the guidelines. And the most important thing is, when they develop the guidelines, they have a technical team which develops the guidelines. At the end of it, they have an independent advisory team, basically made of stakeholders. So they must actually give them corrections and how they have implemented those corrections in the guidelines. So, for example, all that is written in this history section of the guidelines. If you look at Remdesivir, somebody has commented, whatever they have commented is written here in the middle box, and what action they have taken is written in the last box, whether any claim was necessary or any particular action had to be done. For example, people needing low flow supplemental oxygen. One reviewer noted that the wording about an absence of evidence on the use of Remdesivir in children was not accurate because some observational data has been collected as part of the compassionate access program. So what they have changed in the recommendations is, we have not specified that there is no evidence from randomized trials of Remdesivir in children. So basically, they just have to change the corrections and they have given us what correction they have made. So overall, I would say for guideline values and preferences, I give them 5. So finally, what is the purpose of this guidelines? So if you look at the final scope, it says this guideline is for health and care practitioners, those involved in planning and delivering service. It provides guidance and management COVID-19. They have some key questions, and if you see what they have excluded is procuring and distributing medicines and technologies, procuring, distributing and using personal protective equipment, procuring and distributing COVID-19 tests and frequency of staff testing for COVID-19. Actually, when I had pointed out the things which are lacking in this, I had actually mentioned all these. But this was beyond the scope of this current guidelines. So overall, this COVID-19 guidelines, what it has done is it has brought together a lot of individual NICE guidelines and combined them under one huge umbrella, COVID-19 guidelines. My comment about the purpose is it's actually meant for healthcare uses. So the presentation should also be conducive for us to actually go through the guidelines. I felt that it was very dry, like there was no infographic, there was no pictures. So I felt that the presentation of the guidelines could be improved on. And they could have included more flowcharts, diagrams, and tables. There was actually only one entire picture in the guidelines, which was in the supplementary, which is basically how to do a remote consultation. But if you look at the WHO guidelines for drugs, they have beautifully given a nice infographic. Like for non-severe, you give these drugs. For severe COVID, you give these drugs. For critical COVID, you give these drugs. So I would give it 5. And then, suitability for use in my setting, I gave it 4 because of the presentation. Now we come to the last part, whether it's applicable and can you really adopt it to your setting. So you must look at whether they have mentioned on how to tailor the recommendations for the for the local setting. whether they have considered the resources. Have they done a cost effectiveness or cost utility analysis? And have they done competency or training of personnel required? And have they overcome barriers for provider acceptability? So if you look at the cons of this guidelines, there was no final guideline summary document, and there was no explicit barrier or facilitator analysis. There was no mention of competency or training of the healthcare system. Economic analysis was not done. They have mentioned that because it was an urgent guidelines, they could not do it. And there's no explicit mention of dissemination plan. So these are the cons I found. The pros is they have good links to all external documents, and they have frequent links to nice other guidelines also. And they have clearly considered patient barriers under the equalities and health inequality section. Then patient level accessibility for some interventions are also linked. I have already gone through it before. And at the end of it, they have also given an audit tool to see if you can actually do this guidance implementation in your own setting. In the implementation support, they have given us 2 links. One is Royal College of Physicians implementation support. One is measuring the use of NICE guidelines. So when you actually click the first link, you come to this critical care guidelines. But if you click on this, you come to a page saying we can't find the page. So some of them you can't really access the page. The second one, they have given us practical resources. This is not specific for COVID-19, but this is more for like any NICE guidelines, how do you actually apply to your practice. So these are your key things in NICE guidelines, and how to put how to improve the quality of your care. So the audit tool which they have given, you can actually download it like an Excel form. So the first box basically gives you the introduction. The second is all the data sheets, but every recommendation they are given one inside each other. And the final thing is, in your setting, number of relevant or partially relevant recommendations, number of recommendations that you can actually meet in your setting, number of recommendations partially met. So you can use this to audit your own healthcare system. So overall, I gave this applicability 5 and suitability for use 4. Suppose I had actually wanted to see if I was developing my own protocol, or like I'm the administrator of hospital, I actually wanted to know what equipment I need to procure. If you look at the WHO guidelines, they have given really good implementation tools. We have an essential supplies forecasting tool. That means they can sort of like have an app which forecasts what kind of supplies you would need. They also have a toolkit for acute respiratory infections. They have a whole series to actually train your hospital staff. And they also have the medical device list for COVID-19 response and associated technical specifications. So when you click on this, they give you a full document, which is there in the WHO guidance, not there in the NICE guidelines. So when you come to the overall summary of my guidelines, so for the quality of assessment, the overall score I would give was 66%. And then suitability of use, I gave it a 53%. And would I recommend these guidelines for use in the appropriate context? Yes. So within the NHS system, it's an excellent guidelines. But would I recommend this for my context? In my clinical case, it was a secondary hospital jargon. I would say yes, maybe with modifications. So where do you use, which APPRAISER tool do you use? Do you have to use the APPRAISER tool, or should you use APPRAISER? So if you're developing your own practice guidelines, you must use APPRAISER tool to your guidelines and then apply APPRAISER. Suppose you're not developing your guidelines, you just want to critically apply somebody else's guidelines. Are you planning to adopt it into your center or not? If you're not planning to adopt, just do APPRAISER tool. But if you want to see if you can implement it in your center, you first do APPRAISER tool to look at the methodology, and then you apply the APPRAISER to see if you can apply it. So at the end of this, I'll just give a gist of take-home points because other we gone through COVID-19 guidelines. So first important thing is communicate with the patient. Second most important is document everything. These are all the variable therapeutics available for COVID. From this guidance, I'll tell you what they have told. So patients who are not on supplemental oxygen for COVID-19, and they have risk factors for developing severe disease, like they have some underlying lung disease or some cancers. The drug of choice is Nirmal and Ritonavir. And if this is contraindicated, you can get something called sotrovimab. Adults within 5 days of symptoms, you can give molnupiravir. So all the green things are all for mild diseases. All the pinks are for patients with severe disease. So any young person requiring supplemental oxygen, you can give remdesivir. Whoever needs supplemental oxygen, you must give corticosteroids. Whoever is on steroids and supplemental oxygen and mechanically ventilated, you must give tocilizumab. and tocilizumab is not available, you can try paracetamol. Everything which is in yellow, it's only what is available in their NHS through the company. Second thing is what is no longer recommended is your neutralizing antibodies. They're not recommended. Not to be used as antibiotics, azithromycin, ethyl budesonide, colchicine, doxycycline, ivermectin, vitamin D has no role. And they've also given you briefly how to manage acute kidney injury, acute myocardial injury. And so for venous thromboembolism, any young patient and adult who needs supplemental oxygen, you must give the prophylactic dose of low 148 heparin for 7 days. If there is no increased bleeding, you can consider giving it therapeutic dose for 14 days. If the patient is on high flow supplemental oxygen, only as part of clinical trial can you actually give a treatment dose of anticoagulation. And patients who are on anticoagulation for any other condition, you treat it for that condition. Like for example, the patient has rheumatic heart disease, you let give therapeutic anticoagulation. So now coming back to my clinical scenario, so what would I do? So if you see, actually India already has the help of Ministry of Health and Family Welfare, along with AIDS and ICMR, they already have a COVID protocol, which was last published in 2023. What I would do is, I will start off with nice guidelines because it's evidence-based and it's a living guideline. I probably use the evidence from the nice guidelines and update into the existing framework. I would form multidisciplinary teams, and I must ensure that all the recommended drugs are available in the hospital. And I must change the guidelines based on my resources, whether I have oxygen delivery and ICU staffing. Things which we can do in any hospital is the initial assessment and triage. You can use the news to score from the guidelines. Oxygen therapy, you can base it on by using a simple pulse oximeter, which is commonly available everywhere. Anticoagulation for all patients, you can use prophylactic, low molecular weight heparin. For escalation of care, you can develop protocols to shift patients to referral hospitals. And discharge planning, you must, once the patient is stable, and you should also educate the patient about the signs of deterioration. And it's very important to train your staff by giving short training sessions for doctors, nurses, and paramedical staff. And you can also link with higher centers like CMC for online webinars and Zoom meetings for regular update of recommendations. And you must always establish a link with the nearby referral centers, because once you run out of ventilators and oxygen therapy, you must refer your patients there. Thank you.